My name's Joan Stauffer. I manage clinical education programs at IRIDEX, and it's my pleasure to introduce Dr. Adam Lish, who's going to share his experiences using our 810 system for MLT.
Hi.
Thank
you. I appreciate that. I want to thank IRIDEX for having me here, and thank you all for coming out here in Chicago. I want to note Dr. Gasterlin's here, and thank you for being here. Dr. Gasterlin was very helpful when we started using this laser in our practice with the G-Pro parameters. I am a community glaucoma specialist in Brooklyn, New York. I'm a member of a multi-specialty practice. We have glaucoma, cataract, plastics, and a part-time retina person. And I teach in the glaucoma section at Mount Sinai Medical Center in New York. But I am primarily a community glaucoma person. And the reason that that was important in this talk is that choosing this diode laser was an important part of our practice management, and I'll get into that and I'll tell you why. Just some background as to how I sort of view things, and as a member of a group practice with partners whom I answer to, just to let you know the way that I think, and I'm wondering if there'll be some commonality here amongst members of the audience. Of course, our job is to do the best that we can for our patients. It's why we signed up for this all those years ago, and I think we'll all agree that that's what we want to do. And these days, if not all days, fiscally responsible decisions are the catchword. If anyone is from the Northeast, there's a commercial for an investment firm that says it's not how much you make, but it's how much you keep. And I think that for all of those of us who run private practices and private group practices, that's crucial. When we make our equipment decisions, when we make all of our acquisition decisions, we are always thinking about how much we keep. It's crucial to partner with industry, and I think that we're here at the Academy, so clearly we're partnering with industry. It's the private sector that's bringing the innovation to medicine, bringing innovation to the rest of the scientific world, but there's a confluence of interest here. There is the interest that we have as physicians to do the very best we can for our patients, and then there's the interest of the industry. And from time to time, the reps who come in for not just lasers, but certainly for medications or any of the other things that we utilize, may come in and they may emphasize or even exaggerate certain details and maybe not others. And sometimes, and I wonder if I'm the only one who has this fear, that the interest of the industry and of that company may somewhat diverge because of their sales needs with our needs as physicians to take good care of our patients. So when I make decisions in our practice, I have a healthy dose of skepticism. I've become the skeptic in the group. So just a couple of examples of how industry may emphasize things. Anyone here remember there's an alpha-2 agonist we all use with a purple top? I love the stuff. It's on generic now. My patients use it. I would use it myself if I had ocular hypertension. But the reps were coming into the office after the launch of this stuff, and they were saying, "Doctor, you have to use this because it's neuroprotective." I said, wow, neuroprotective, gee whiz, I teach at Mount Sinai. I know they're part of the phase 4 memantine studies for medication that's used in Alzheimer's disease to protect the nerve, and this is great. Is this neuroprotective? And the rep kind of look at me and say, well, we think maybe it is. And then sure enough, if you ask enough questions and you drill down and you ask around, and you look at the footnote, there was a mouse study where the medication was injected into the belly of some mice, I don't know how many, and then they harvested some of the organs to see that the nerve endings in those organs were perhaps somewhat protected from crush injury or another insult. Now, that's not quite applicable to glaucoma, and once you get into the science of it and you ask the rep will say, well, I have to speak with my supervisor, and sure, doc, you're correct. But once you tell people that, and once the word gets out, the statement neuroprotective, unfortunately, people remember it. And as a glaucoma specialist, I go to meetings and speak with people, and they say, oh, you're not using that alpha-2 agonist with the purple top? Doc, isn't it neuroprotective? And I found myself giving this speech over and over again. Listen, I love the stuff. It lowers pressure. If you're not allergic to it, I use it myself. Stuff's great. But let's be careful when someone tells us something is neuroprotective. Two other examples. There was a multifocal IOL in the 90s that reps were coming in and saying, you got to use this for your patients, doc, because if you don't use it, you're not cutting edge. And sure enough, this lens was pulled off the market soon thereafter because the marketing was an ophthalmologist with his little gray-haired mother. And his little gray-haired mother was very happy. Well, my little gray-haired mother, who's taller than me at this point, wouldn't have been happy with me because she likes to drive at night. and you could not use this lens to drive, and it was pulled. So we're here talking about laser technology, and of course, as a glaucoma specialist, I was looking at all the other lasers, and I was looking at SLT. And I actually, and thank you, Brian, for reminding me of this story, I was standing at a booth that sells another laser, the SLT, and I was looking for lasers for a practice, and I was told, Doc, if you're not doing SLT, you are not practicing standard of care. I said, what? I said, I've been using my argon for years, and argon laser is great. We have a solid-state argon. It's 10 years old, and it's showing its age. I got to replace this thing, and I want to replace it responsibly because, like I said, I got partners that I have to answer to. He says, no, this is repeatable, this laser. I said, wow, I'm missing something. So I went to the literature, I went to my peers, and sure enough, there's no literature to discuss repeatability. Then, now there's some, and we can have some conversations about repeatability, but the reps in industry was telling the physician, doctor, you have to do this because this, and this. And I think that we all need a healthy dose of skepticism when viewing all of these new technologies, medications, and procedures. So that's how I think, and that's why as a community glaucoma specialist, I was eager to come speak with you. So in my practice, we needed a laser. We had a solid-state, coherent, for those of you who know history, coherent solid-state laser. Thing is great. It was blue-green. I, as the glaucoma specialist, used it for my laser trabeculoplasty, iridoplasty, cutting sutures. For a retina specialist, used it for macular work, for PRP. It was a workhorse. It still works. I use it to cut sutures occasionally, but certainly it's not dependable enough for some of the detailed work that we do. So I needed to come and buy a new laser. When making big decisions, I like to go back to what I know. And much to my wife's chagrin, I think I save every piece of paper that I've ever generated. And I had all the documents left from my fellowship in the early 80s, and the early 90s. Don't want to age myself too much. And sure enough, we had used a diode laser at Mount Sinai. Diode back then did not have micropulse, which we'll get into in a second, and it was certainly worked. And when you go back to the old literature from the 1990s, sure enough, you could use several different wavelengths to do laser trabeculoplasty. You can use krypton, you could use YAG, you could use argon certainly, and you can use diode. So now all of a sudden, that other company that was telling me I wasn't practicing standard of care would have to answer to themselves because there were plenty of other places to look. IRIDEX is a company that I know well from when I was a fellow. I've mentioned to some of you, my wife's a dermatologist, and she uses her IRIDEX laser to take care of pigmented lesions and blood vessels on the skin. So at a meeting here a few years ago, I made my way over to the IRIDEX booth and started to educate myself. And lo and behold, the literature from the 90s, the paper by Moriarty, the several papers, and then some recent papers, which the reps here I'm sure will hand to you, show that diode does indeed work. It's as efficacious as argon. And lo and behold, when we look at the claims of SLT about cold laser and not doing damage, the new micropulse technology does the same. But again, this is a claim, and I was as skeptical about this as I was about all of the other technologies. I said, look, it's very nice that you guys are telling me cold laser, it doesn't do any damage to the trabecular meshwork, but I really need some more information. So from attending the AGS and reviewing all of our posters, sure enough, with electron micrography, they were able to show, and thank you to the Saunders-Noreca group and to the Fudenberg group who will show next, I was able to be given real data so I can make the decision as to whether I would utilize this technology for my practice. And sure enough, while this doesn't come up in clinical practice too often, I like these two papers because here are the light microscopy on top, normal trabecular meshwork, argon laser treated trabecular meshwork, where you can see the damage, SLT, which certainly is a good laser and does what it says. There's no question it does not cause damage, but certainly micropulse laser technology with the 810 diode also does not damage the trabecular beams. A better example of that are the Fudenberg slides, excuse me, which I think are on the floor as well. And you have the ALT here, SLT here, and you see the trabecular beams in both the SLT treated quadrant and the MLT treated quadrant do not sustain the coagulative damage that argon caused. So now I had a laser which, and I will say, was significantly less money than the one-trick pony SLT. I had to answer to my partners and say, guys, we need to buy a laser. I can buy one laser which is going to do what my coherent laser did for all of those years, and with our diode. I do laser trabeculoplasty. My results are fine, the same as they were with my argon. My patients are more comfortable with less inflammation and no synechia formation, which trabeculoplasty, as we all know, argon laser is about 30-40% rate of anterior synechia. I do my iridoplasties. I cut sutures. I work on laser iridotomies. I'll pre-treat with diode, and then I use a YAG laser to go all the way through. And I do G-probe for my end-stage glaucoma patients. My retina person is evaluating a headpiece for some retinal work as well with the same machine. So here we have one instrument which I was able to bring to my partners, and I was able to say, guys, this is the way that I can continue to do the best for my patients. And yes, I'm being fiscally responsible here. I'm bringing a piece of technology into the office that's solid state that I can vouch for because my wife even has one. I've known the company for years, since I was a fellow in the 90s, and they were willing to give me their data, and the people who are spokespeople for them were willing to share their electron micrography so I could bring this to you guys. So the parting message, I think, is, for me personally, that my healthy dose of skepticism, I think, leads to better care and better decisions. Thank you.